Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based in DRC. I will now hand it over to him to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, depending on which part of the world you are in. We would like to welcome all of you again to this press conference of the week. And we are happy to have you at this very interesting moment of our effort to control Mpox on the African continent. We had a very interesting last week with the two emergency consultative groups of both WHO and Africa CDC making a decision to extend the public health emergency of international concern and continental security on Mpox. Now we are in the immediate aftermath of those decisions, working on the new plan, which is the acceleration plan, to really help us in the next coming months to control the outbreak on one part, and then in the later part of this plan also leave a legacy behind. I think we are pleased really to have you and provide you an update on where the outbreak stands on the African continent. With that, Director, I think we can move on to the presentation. Yes, thank you. Just some of the key update. As I just said that there was a recommendation from the emergency consultative group to extend the fix, and the Director General of Africa CDC has accepted the recommendation and declared the extension of the fix, which is the public health emergency of continental security, for another 6 months. And in that regard, the incident management support team is finalizing the next plan, which will focus on intensification on one side, but also integration, as we know that we need to leave this Mpox vaccination as part of the routine services and also leave a legacy with a much stronger system to prevent, to detect, and also to respond to the Mpox outbreak in the future. On the vaccine front, we've seen very encouraging results on the vaccination in DRC as part of the intensification. More than 300 people have been vaccinated in Kinshasa alone in just about 10 days, really more than double, I think, what was used during the face-to-face. And also combining both the North Kivu and Sud Kivu, we have now about 605 cases that have escaped Mpox treatment centers because of the conflict going on in the eastern DRC. And finally, some concerning news from Uganda. After more than 20 days that they did not report any case of Ebola, now there are 5 new cases that have been reported, 3 confirmed one, and 2 probable cases. Next. On the Mpox front, since the beginning of the year, we have 24,272 cases that were notified, of which 6,034 confirmed, 260 deaths among suspected cases, and 25 among confirmed cases. From a total of 15 countries that have reported so far. Also, Angola has reported 2 confirmed cases after also spending almost 2 months that there was no confirmed case, and these come from the 2 provinces of Muigai and Kwanza Norte, which are all bordering the Democratic Republic of Congo. As I said, out of the 22 countries that have reported Mpox cases since the beginning in 2024, we have 15 that are in active phase and 7 that have remained in control phase. And specifically for week 8 of 2025 that we are reporting, we have 11 countries that notified 2,610 cases, which shows an increase from 1,959 in week 7. of which 664 were confirmed, also in comparison of 535 the week before, and 45 deaths compared with 42 deaths the week before. I think that is the situation on week 8. Now, trying to do a deep dive on DRC in particular, DRC has reached a total of 78,690 suspected cases since the beginning of 2024. 16,255 confirmed, 1,560 deaths. That gives us a case fatality of 2%. But for the specific week, AP week 8, there were 1,918 cases that were notified in comparison of 1,463 the week before, which shows an increase in the cases notified of 31%. There were 202 cases confirmed, very much comparable with the 201 reported the week before. The number of new deaths among confirmed cases is 2, and the number of new deaths among suspected cases is 44. Again, compared to 39 the week before. But the reporting coverage is still a big challenge. We had 7 provinces reporting during week 8, just 1 province less compared to the 8 that reported during week 7. And of the total cases, we still have clade 1A and 1B that are co-circulating. As we reported last time, the new mutation of outbreak 3 on clade 1 has been reported in Kinshasa. Now, some of the challenges are related to the testing coverage, which again declined from 27% the week before to 17%, but a testing positivity which went up from about 47% to 60%. What we are seeing, we see a declining trend in confirmed cases when we look at the situation over the last 5 weeks. But some of that can also be explained by the situation which has happened with the insecurity in the east on one side, but also the declining in the testing coverage that has gone down about 10 percentage points. Next. The humanitarian crisis in the Eastern DRC is the one that is really of great concern to all of us for the response. Over 2 million persons that have been displaced internally, and some have gone across the borders to Uganda, Rwanda, and Burundi. We have more than 600 cases that escaped the Mpox treatment centers in the Eastern DRC following the conflict. But we hear the good news that in Bukavu, there are more than 150 that have come back, mainly because these were severe cases that have really returned to continue the care with the slow reestablishment of the security in the area. But at the same time, the DRC Ministry of Health has developed with Africa CDC and other partners support an emergency response plan that also includes Mpox outbreak response into it. And on our side, as the IMST, we are working on a cross-border strategy that will help us coordinate the response across Uganda, Rwanda, Burundi, and the DRC, and also see how we can intensify the surveillance, we can intensify the vaccine and community engagement. Next. Next slide, please. Now, some of the achievements that we wanted to report this week, we start with the decentralization because we just say that the testing rate is going down. But at the same time, we have seen very encouraging progress on the decentralization of laboratory capacity in the DRC. In July 2024, just a month before the declaration of the public health emergency on Mpox, there were 2 laboratories that could actually perform the Mpox testing in the country. By December, we moved up to 12 laboratories in 8 provinces. And now, last month, February, we reached 21 laboratories that do have now capacity to do Mpox testing in 12 provinces. As we can see that the number of laboratories is going up, the number of provinces also performing Mpox testing is going up, but the challenges that are left is mainly the sample transportation, as we have reported, because of the freeze on US funding, but also combined to that is always the insecurity that has also contributed to the slowing of the arrival of the samples in the laboratory for testing. Next slide. We also wanted to report some of the progress we've observed on the IPC, an area that is one of the key pillars of the response, especially on the prevention side. In October 2024, we had a total number of reported healthcare workers that were infected at 104. And in January 2025, that number has declined to 52. That shows a reduction of 50% in healthcare worker infections. Now, some of the interventions that might have contributed to that, it is the training and mentorship of healthcare workers and community health workers in IPC-based practices. I think about 600 of them that were trained. We have also provided support with the procurement and distribution of IPC supplies. And we have also developed the IPC standard operating procedures and the guidelines that have been disseminated in the health facilities to ensure that the basics of infection prevention and control are applied as part of the care. On the vaccination front, we have 8 countries that have received vaccines, but there are shipments that are being arranged also this week for additional countries, including Kenya, that will receive it for the first time, and countries, but there are also shipments to 3 countries that had already received before, that's Uganda, DRC, and Nigeria. We have 5 countries that are currently vaccinating, and the total number of persons vaccinated with at least 1 dose has now reached 420. And there are 12 countries that have granted the emergency use authorization for the MVA-BN vaccine. And we also wanted to just report on the progress that has been made with the launch of the new vaccine acceleration plan in the DRC that started in Kinshasa. Very important to see that in about 10 days, Kinshasa has vaccinated more than 300,000 people. You know, a good testimony of the high acceptance of Mpox vaccine among the communities. But this time also, as we reported last time, that the guidelines were changed in DRC to include the vaccination of children below 18 years. And in the number that we've just reported now, about 38% of the total number of people vaccinated were children between the age of 1 to 17. And the vaccination coverage in Kinshasa now stands at 51.6% of the initial target for this new intensification phase. I think that's it on the Mpox front. Now we can move on to the Ebola virus in Uganda. As I said, after 20 days that there were no cases from the initial cluster, now there's a new cluster that has been identified with 5 new cases, of which 3 confirmed and 3 probable cases, Of the 3 confirmed, I think one has died, and the diagnosis was actually made of the 9 cases that were reported before, identified on genomic sequencing. Now, of the confirmed case, of those confirmed cases, we've also seen the listing of the contact. There are 69 new contacts that have been listed, and all of them are currently under follow-up. Just to say that even the other 2 confirmed cases also came from the list of contact, which is good news that now when cases come out of the list of contact, it shows that it is a chain of transmission that is under control. Now, cumulatively, this now brings Uganda to 14 cases in total, 12 confirmed and 2 probable, and 2 that have died, with a case fatality now at 16%, which include 1 healthcare worker and then the 4-year-old boy. And the total number of contacts from the first cluster to the second cluster is 489 contacts. And now the total number of districts has reached 5 districts. That's 2 new districts adding to the 3 that were there before. And also very important to say that this is really the first time that we have Ebola reporting starting in Kampala, in a big city like Kampala, meaning that there is still work to be done to identify the initial index case that might be linked to some zoonotic transmission. Now, some of the response to the Ebola, that first there has been a reinforcement of the rapid response teams, 12 epidemiologists and IPC specialists that have been deployed. In addition to that, we have supported the training of about 736 community health workers to support both the RCCE, the IPC at community level, and also the community-based surveillance. In addition, we are also supporting the deployment of emergency supplies. We'll be delivering very soon 2,000 doses of remdesivir for the treatment. In addition to that, we are also facilitating the strengthening of the cold chain, with cold chain equipment and other supply being distributed. And we are also providing the supplies for laboratory diagnostics. On the vaccine front, 264 contacts that have been vaccinated so far. And we are also collaborating on the vaccine trials. And finally, we are also working on pharmacovigilance ready to monitor the adverse events that are following the immunization in Uganda. Next. The situation in Tanzania has remained unchanged. As of May 1st, 2025, no new cases that have been reported, meaning that we've moved now to the countdown. It is 32 days now since the last death was reported. However, recently, as of March 1st, there were 50 new alerts that were received, but none of them was validated. I think that's where the Marburg situation stands in Tanzania. Next slide. And finally, is on the cholera front. During EP Week 9, there were 958 cases that were reported compared to 807 in Week 8, showing that the cases are still on the increase. But on the case fatality rate, we now stand at 2.9, which shows already a decline related to all the improvement that have been made in the treatment centers. 28 deaths reported during Week 9. The epicenters of the cholera outbreak are 2. That's the provinces of Bengo and Luanda. But looking at the distribution of the cases, males make 56% of cases and 59% of all deaths. Among the age groups most affected, we have the under 15-year-old making 39% of all cases and 35% of all deaths. Now, in total, since the beginning, Angola has now reached 5,872 cases, of which 208 deaths and 3.5% case fatality overall, with about 13 provinces that have been affected. Next. We also wanted just to say a word on the febrile illness in the DRC. As of 2nd of March, there were 580 new cases that were reported, suspected cases, not to make a total of 1,522, and there were 4 new deaths. As we can see, that's now less than 1% case fatality rate, also showing that the case management has been improving. The total number of deaths since the beginning is 56, with a case fatality rate overall of 3.7%. But the symptoms remains the ones of a febrile illness dominated by fever, chills, sweating, headache, muscle pain, neck pain, joint pain, anorexia, vomiting, diarrhea, dyspnea, and restlessness. There is no history of travel, and this febrile illness is concentrated in 5 villages in the province of Equateur. Now, of the cases that have been reported, the children below 5 years make 18% of cases, and the 5 to 15 make 20% of cases. That's a total of 38% among children below 15 years old. And on the diagnostic, malaria still remains the first diagnosis, with the RDT, the rapid diagnostic test that were performed, that found almost a 56% positivity rate, and blood smears also were performed, 77.9% positivity rate. That's the reason why I think the current working diagnosis is malaria, both in the case management. The tests were performed for Ebola and hemorrhagic fever. They were negative. As you can also see on the symptomatology, there was no hemorrhage that was also reported. Next. Now, in summary, the Director General has extended the FEC for another 6 months. Now we are busy really working now on the plan that can capture all the strategies that have been identified for the intensification, that include really a very strong community response to improve on community-based surveillance, to improve on risk communication and community engagement, to include on IPC, very important component. But at the same time, it's also the decentralization of laboratory that is a key component of this acceleration phase, and the acceleration of vaccination, as we just reported, as it has already started in Kinshasa with very positive result. The challenges remain, I think, 2 most important ones, the recent growing tension in the DRC, for which it is important, really, if we are to make progress during this second phase, to really have some settlement of the insecurity in the DRC, very important. And the second is the challenges related to the cancellation of some of the funding from the US government on these interventions that are also affecting Mpox. And we are busy now working with the member state and partners to find alternative sources of funding to mitigate the impact of those measures. Ebola in Uganda is also a very important challenge, especially the resurgence of these cases. However, I think everything is being done in the country to intensify really the monitoring of contact around the cases that have been identified, to have very active surveillance around that. The 2 cases have been isolated and they are getting care, but it is important to also understand that this poses more challenges for Uganda to be dealing with two major outbreaks at the same time. I think we have seen the dedication, I think, or effort are being made to make sure that the main challenges related to the sample transportation is addressed first with the decentralization of laboratories to the health zones to really minimize the need for transportation, for long distance transportation, but at the same time also with the effort to mobilize both domestic resources and the resources from the key partners to be able to fill the gap that has been created with the US funding freeze. To update today, and questions from the participants.
Thank you very much, Dr. Ngashi. Let's take the first two questions from the chat group. We have Dylan Gamba, a journalist at Agency France Presse. He's asking about the UN appeal for funds for Uganda. And the question is, what is the status of funds allocation for Ebola Sudan in Uganda, given that there's a lot of appeals for funding, especially from the UN? The next question comes from Evelyn Musambi of Associated Press, based in Nairobi. She asks, on DRC Mpox response, what's the latest about response efforts like delivery of vaccine, especially in the East? And what about the health facilities lacking resources or where patients have fled? What's the status on that? Over to you, Dr. Ngashi.
Okay, just the three questions from the last on DRC. Is the vaccine delivery in the East? And what else?
Yes, and then the other one is on the vaccine delivery, and then the status of the health facilities lacking resources, given that patients have fled. What's the status on that?
Okay. Yeah, thank you very much. I think for Uganda, the question is about the UN funding. No, I wish we had colleagues from WHO to be able to respond on behalf of the UN. But what we have seen on the ground, I think there was a meeting that the minister, Her Excellency, the Minister of Health, convened in Uganda with all partners to look at the needs and also invite partners to be able to indicate the areas of support that they're interested in. I think partners came forward and indicated that. And we did also the same as Africa CDC. I think in the areas that Africa CDC is committed. I think that's part of that I indicated the fact that we committed to providing some additional human resources with the epidemiologists and IPC specialists that we have assigned to Uganda. We also committed to help with the treatment. I think that's the reason why we are bringing the 2,000 doses or 2,000 treatment of remdesivir. We also committed to support the community response for which the government requested that we do help train the 7 that they offer to us. In general, it seems that all the partners have really mobilized all the support that is needed so far. We haven't had any, at least the few cases that are there for the. On the DRC, the delivery remains a challenge because of the insecurity. As you know, that is not the lack of vaccine, it is just the security situation to allow us to go in. You might have heard that many international organizations, including humanitarian organizations, removed the non-essential staff from the East. I think that also affected even Africa CDC. We also had to take out our staff out of the Eastern DRC. But we are just waiting for the opening of the humanitarian corridor that has already been requested and it's also being negotiated right now. And the situation seems to be normalizing slowly. We hope that very soon that corridor will open up, and then we'll go in and provide the vaccination. And remember that Sud Kivu is the epicenter, of the Mpox outbreak, especially the clade 1B, which is what everybody's just waiting after Kinshasa, looking at the success of the vaccination in Kinshasa. We're thinking that Sud Kivu is the next in line as soon as the security situation allows. Now, on the health facilities, I think there were some health facilities that were destroyed. I think that is the reality. But the government has come up with a plan to restore those health facilities and also provide the necessary commodities. I think all of us have been invited also to make a contribution, and there are many partners, within the IMSC and beyond, I think, that are working with government to contribute to the budget and also to the essential commodities that they have requested. I think it is part of the restoration. I think that is going on, and we hope that looking at the goodwill, that they should be very soon to establish that. But the first and most important thing is the security situation to allow for the humanitarian assistance to kick in.
Thank you. Let's move on to the floor for extra questions.
Over to you, Director.
Thank you. We're going over to the floor for extra questions. We have Kerry from Health Policy Watch. You have the floor.
Thank you, Margaret. Dr. Mbongo, please could you remind me who the target is for the vaccinations in Kinshasa, because you said that over 50% of the target had been vaccinated. And then I wonder if you could just speak a little bit more about this new variant. You mentioned last week that it might be more infectious, and I wondered whether you could just give more information on why you think so. Thanks.
Thank you. Let's take the next one. Esther Nakazi, a health journalist from Uganda. You have the floor.
Thank you, Margaret, and thank you, Dr. Ngashi. My question is about the transportation of samples. Can you please explain how many hours, how many days before the US freeze would samples take from one point to another as compared to now without the funding? And I also want to know how many vaccines are we expecting, Mpox vaccines in Uganda next week? And are the 18-year-olds going to get the vaccines in Uganda, or it's another age group? Thank you very much.
Thank you. Over to you, Dr. Ngashi.
Okay, Kerry, I heard the second question about outbreak in Kinshasa. It's like she had another question that was related to the 51% in Kinshasa that we did not hear fully. I don't know if you got that.
What I wanted to know is who is the target? You mentioned 50%, over 50% of the target group had been reached. I just wanted to know who the target group is, please. And then I also asked about the infectiousness of the new variant. Thanks.
Okay, thank you very much, Kerry. Now, this time, the vaccination acceleration plan in Kinshasa had two different strategies. One is the geographical approach. I think that's the one that was applied now, where in the community that is the hotspot, reporting the highest number of cases, everybody in that community from 1 year and above was vaccinated. I think that's the number that we've just provided. But in the non-hotspot communities, I think the target was mainly on contact, on the contact of confirmed cases. Now, I have to say that there was already a first round. I think that's targeted healthcare workers in almost all the health facilities and also key populations. I think those are the targets of the vaccination campaign in the DRC. Now, on the question about outbreak, outbreak is a gene that has been identified in clade 1B. That in a way, has been also linked to the high transmissibility of clade 1B. Now, the new discovery that that mutation has been now found in clade 1A, and then raises concern about then the changes in the transmissibility of clade 1A as well. I think that's something that we are really under the watch to see how that mutation in clade 1A is going to play, if it is going to confirm the fear of the high transmissibility as that has been documented in clade 1B. Now, on the on Esther's question about Mpox in Uganda, Uganda has been allocated 100,000 doses of vaccines, and already now I think the first shipment is of 59,000 that is coming, and then the remaining 41,000 to follow. And the second question, yes, please, Esther, if you can go ahead.
Yes, the second question was about, you said samples, Mpox samples are being delayed because of the US funding freeze. And I want to know, to get a sense of time, is it days, is it hours, is it seconds? How long is it taking in the different areas in Kinshasa and in the countries that are affected? Thank you so much.
Yes, I think the assessment of the duration of sample transportation has gone, I think within 48 hours, it's about half of the samples are transported within 48 hours, that's 2 days. And then there's another about 20 to 25% that go up to 7 days. And then the remaining 20 to 25% go up to 21 days. But in this case, it's not even a delay. It is just it has stopped completely because you remember with the freeze, USAID stopped funding. You know, if they stop funding, that means that the samples are collected, but there are no more transportation. There's no more transportation to the CAO facilities or the laboratory where the testing is supposed to take place. That is what explained, as we say, that we see a 10% drop, you know, in the testing coverage, where it has moved from 27% to 17%. That is what that freeze is causing. Now we are in the immediate, they are trying to find alternative source of funding, that is one, but at the same time, we are also accelerating the deployment of vaccines to the health zones. As you see, of laboratory equipment to the health zone. As I reported, we've now reached 21 laboratories, but the target was to reach 56 laboratories as part of the decentralization to be able to get all the health zones, have laboratories within the health zones to then eliminate the need to transport samples outside the health zone and even outside the province for some cases that have to go to the major laboratories either in Goma or in Kinshasa.
Thank you. Let's move on to the next question. Thank you. We have Gabriel Emmanuel from NPR. You have the floor.
Thank you so much for doing this. I just actually had a really quick question about the testing rate that I saw on the DRC. It had dropped to 17 for some percent. And I wanted to know what it was at its high point and when that was the case. And am I right in understanding this is, of the suspected cases, the percent that are tested and confirmed, or that are tested, sorry. Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. Priyanka from Chemical and Engineering News, you have the floor.
Thanks, Margaret. I have two questions, actually. My first question is, I know a few meetings ago, Dr. Ngashi, you had mentioned that there were investigations underway to figure out what the source of the Ebola outbreak was in Uganda. I'm guessing that means trying to figure out how the nurse, the first known case, got infected in the first place. And I was just wondering if you had any updates on that front. And my second question is, I guess my understanding is that epidemic intelligence officers are deployed sometimes when these outbreaks happen. And these are folks that are typically trained in Atlanta, in the US. And I was just wondering if in the current outbreaks, because of everything happening in the US, there's been disruption on those folks being deployed, and has that been a problem? Thank you.
Yes, thank you very much. Yeah, thank you very much, Gabriel and Priyanka, for those questions. On Gabriel's question, the testing rate is dropping, meaning that there are suspected cases. Those are cases that have been investigated and confirmed that they meet the definition of an Mpox case, that then the samples were collected. But then, unfortunately, at the end, those samples did not get the chance to be tested. Before, at the beginning, the testing rate had already reached 35%, and then it went down from 35% to 27%. Now it has gone down to 17% because there is no one that is paying for the transportation of those specimens. I think that is what I was reporting, that the lack of funding for one to pay for the samples to leave the health facilities in the province and go to the laboratory that has capacity to do the testing for them is really becoming a major challenge that requires quick alternative solutions. Now, on Priyanka's question, very interesting question actually that is of concern to all of us in a nurse. This nurse had visited several health facilities, but then the question is, because in most cases, the first case is of zoonotic origin. I think usually from people that live in contact with animals, and that's what it starts, and then from there, they go to a health facility, go to their community, and then start spreading from there. But this time, we have something that is happening on a nurse that is living in the city. Now, the question is that most likely this nurse might have been in contact with another true initial index case that is still being under investigated. I think that's the reason, one of the things to look at first among those 9, the initial cluster of 9, if, for example, the nurse wasn't the index, but there was another index, but also investigations are also going even beyond that to see if there are other cases which might have been missed before this one came forward. What we know is that the country is investigating, but they haven't yet gotten to the conclusion. But I have my colleague who was in Uganda right now, Dr. Have any latest on the investigation of the original, most like original index case?
Hello, if you want me to chime in. So 2 things we know so far. From the sequencing they've done, it shows that it's almost 10 years apart. So it can be a human-to-human transmission, like you said. It is zoonotic. It seems to be most conserved, further reinforcing that from the healthcare worker, there has not been much human-to-human transmission. The sequencing done among the other confirmed cases all linked to this case. But as Dr. Ngachi correctly said, the unknown is the intermediary before this index case. So a couple of things were planned. The last one we're discussing with the scientists to do what we call the retrospective serial survey, to take all of the contact and their friends and see the serial survey and then do an in-depth ecology and to be able to trace the real origin. What we do know is a zoonotic event, 10 years, more than 10 years apart, but the true index case is still being investigated, and the serial survey is being conducted to look at RGM and RGT. That will then begin to point to the most likely source.
Thank you very much. Let's take.
Thank you very much, Papa.
Oh, Margaret, I was just wondering if my second question could also be answered.
Yes, the second question is about how the US decisions are affecting the deployment of experts, I think, in the response. So far, not yet, including ourselves. We do have 11 staff seconded from US CDC. We had a conversation with US CDC. We are reassured that for now, we are not yet affected. We continue using the staff, as initially planned. That is just an indication that on that side, because the deployment of expert epidemiologists and so on comes mainly from US CDC, it is an indication that so far that area might not have been touched yet.
Thank you very much. Let's take the next two questions. We have Lucia from the Spain International News Agency. You have the floor. Lucia, can you hear us?
Sorry. Yes, can you hear me? Okay, thanks so much for your time, Doctor. My question is about numbers. You gave us the total number of cases and deaths of Mpox since January 2025, but I was wondering if you could give the total number since January 2024, so that we have an overview of the impact. And then just a quick question regarding the Marburg outbreak in Tanzania. You mentioned that 32 days have passed since the last case. Does that mean that the 16th of March would be the deadline for the outbreak to be considered over in cases, of course? Thank you so much.
Thank you, Lucia. Could you repeat your first question? It was a bit.
Sure.
Yeah.
You can hear me now?
Yes, we can hear you.
Yes. So my first question was regarding the numbers of Mpox. You gave us the total number of deaths and of cases for Mpox since January 2025, but I was wondering if you could give us the total number since January 2024 to have a bigger overview of the situation. Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. Makochi from BBC, you have the floor. Makochi, can you hear us? Makochi, can you hear us? Okay, let's take Oscar from Spain News Agency. You have the floor.
Thank you very much. Thank you very much. I wanted to ask you about the febrile illness in the Equator. What does it make? Why are you saying the same illness in all the cases? No? Why is it? Because you have some with malaria positive, others have blood smears. I wanted to ask you, what is it a virus? What else do you know about it? And then how is it being treated? Because you mentioned 5 villages, but I don't know where are they, these people are like the cases, where are they being treated, and in which conditions, and what do you know, what is the feedback from the place?
Dr. Ngashi, over to you.
Yes, thank you very much for those questions to Lucia and the colleague. On the first question, I think Lucia wanted to know what's the total number of cases.
Dr. Ngashi, we could hardly.
After the testing, the diagnosis
Dr. Ngashi, can you hear me?
Yes, I can hear you. Can you hear me?
Yeah, so the last responses, we couldn't hear anything from your end. If you could repeat the responses to the last two questions that were asked.
Oh, the last two questions were about the case, the febrile illness. I think that the colleague was wanted to know how the treatment is being conducted. And I reported to say that before the diagnosis was really confirmed, they were being treated with a diagnosis a differential diagnosis that looks at malaria, typhoid fever, and intoxication. But now, after the confirmation of the malaria diagnosis, the focus has been now on really treating them in the health facilities for malaria. And as we can see, even the data that I presented, it really shows that there is an improvement in the case fatality rate, which has gone from 3.7% overall to less than 1%, for the last week that I reported 580 new cases, but only 4 deaths that have been reported. That shows that somehow the malaria treatment is responding well. And there was another question was on the number of cases since January 2024 that I said is around 110,000. And also on the 42 days of the Marburg in Tanzania that I say that yes, I think we are 32 days, 10 more days to go to complete the 42 days that are considered for the 2 incubation period of 21 days to have the assurance that we have now the outbreak under control. I think that would be around 16th of March that Tanzania would have completed the 42 days.
Sorry,
Thank you
very
very
quickly regarding my question, you said the total number of cases, but you didn't say which ones are confirmed and which ones are suspected, and also the number of deaths. If you could give us an estimation or the exact number. Thank you so much.
Yes, I think okay, let me see. The number of confirmed cases, the total number of confirmed cases from 2024 should be around 25,000. Messi, can you just confirm the numbers, the exact numbers of confirmed cases? If we can confirm the number of the total number of suspected cases, confirmed cases since January 2024 to week 8.
I can't see Mercy on. Dr. Ngashi, Mercy is not on the call.
Oh, Mercy is not connected?
No, she's not on the call.
Oh, Amadou, if you are connected, can you check on the numbers quickly?
While we are checking, let's take the last question from Makochi of BBC, if you can hear us. Makochi, can you hear us? Okay, I think he's not there.
Yeah, I think we are just checking the numbers quickly for Lucia.
Margaret, while we are waiting, if you are listening to me, I want.
Oscar, can you hear us?
Yes, can I hear you? I wanted
Yes.
to ask you if we are still waiting about this febrile illness that you have mentioned that all the cases have been found in 5 villages, no? That is kind of scary in the sense that which is the prevalence in those villages of this illness. But anyway, there are also no guarantees that we are talking about the same thing, no? Maybe they can be like a lot of factors. Because of malnutrition, because of the season, because of many things that the symptoms make us think that they are the same thing, but maybe there are different things in every case. Or because if not, if it's something really that is being caused by one source, by one index case, then it seems that to be like a very dangerous thing, isn't it? If it's 5 villages only. And then I wanted to know, where are they treated? If they have been taken to Mbandaka or to one place or an isolation treatment center, or whether they are in the normal facilities. Thank you.
Thank you, Oscar.
Okay, I have the response for Lucia. I think the total from January 2024 to February 2025 is 100,912 suspected cases, 21,577 confirmed, 1,516 dead, and all that from a total of 22 member states. That is on the Lucia's question. And then on the last question, just to explain that these cases are happening in what we call the health zone. Health zone is like a district, of Basankuso in the Equatorial province. That is the northwestern part of DRC. And every district has got a hospital, which is the referral hospital of the district. That is why these cases are being taken care of. And they are, in those 5 villages within the same health zones. And you remember even the similar situation in Panzi. There was an investigation that was conducted, and then it found that there was most of these cases were associated with malnutrition. No, it's also the same here. The conclusion is not yet given. I think we hear that there's an investigation that is going on. I think that includes both the Ministry of Health and also the ENRB, WHO, and also Africa CDC. I think once that investigation is concluded, then we'll be able to give really the fact in terms of what has contributed to this high case fatality rate and also to the outbreak itself, the factors that have triggered the outbreak. But so far, the information that is clear is on the diagnosis part of it, and also the case management and the zone that it is happening. That is what we know. And the facilities where these cases are being treated, that's what we know. But as soon as the investigation is completed, then we get much more information on the factors that might have contributed to the situation.
Thank you very much, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I'll hand it over back to you for your closing remarks. Over to you, Doctor.
Yes. First of all, just once again to thank all the participants for the great interest that we've seen really in these weekly briefs. That it also puts some sense of accountability that we have toward you to make sure that we let you know how the situation of outbreaks is evolving on the continent. This is a time of, at the same time, we see some light at the end of the tunnel, for the positive things that we are seeing and the interventions that are now scaling up to really reach the scale that is needed to see the impact. For example, we're all concerned about vaccination, that close to 700,000 doses that were distributed, only 100,000 that were administered. Now we see that is also changing. Now it is 420,000 doses that have been vaccinated. And if you see now, we've seen even the number of people vaccinated in one single day reaching 50,000 in one single day. That shows that with the high acceptance, we are also now getting into the coverage of this intervention that will give us the impact that we would like to see. The challenges are there. I think we are working on them with the two most important one, which is the insecurity on one side and then the funding challenges on the other side. We are all working on that. I think all the partners are mobilized. We are also mobilizing the member states themselves because the solutions have to start to be local solutions in addition to what we can get outside of these member states. I think all those are things that we are working together, and we wish that as we move into this new phase, the intensification plan gets now adapted and customized to the national level to also reflect the same acceleration strategies into national plan. We should be able, during the duration of this plan, to see some encouraging progress. We are very much mindful of the global landscape, that funding is not going to last for forever, and the patience is not going to last forever. That's why we really also feel pressed really to accelerate, to make sure that in the next 3 to 6 months, we can see some good result. Why not? That can really lead to the lifting of the status of public health emergency. I think with those, I would like really to thank you sincerely for joining us again today, and wish to see you next week at the same time on the same day. Thank you very much.